of the Merit Nursing webinar series. I would like to especially welcome Dr. Rafat Jan and Dr. Shahid Rafiq, who have kindly joined us today, and they will be participating in this seminar, in this webinar today with us. This is the end of the journey through critical care, although I don't quite agree with that, and I'll tell you at the end why. This is one time that I do not agree with the end of the journey. So let's continue. Next slide, please. Okay, this is again, as it says, the journey ends, and we will see a new beginning after that. The last session of the nursing journey in critical care in the case of Mrs. N, presented by Shabana Ali, Dr. Mohsin, myself, and Dr. Rafat Jan and Dr. Shahid has joined us today. I would like to kind of take you back to July the 11th when we first started the webinar. And today is the 8th session of that webinar. The objective of this webinar was to talk to nurses that were relatively new to the ICU environment, especially in the middle of the COVID pandemic, so that we could assist in helping them manage patients that they have not seen or managed before, not being new to critical care. Our next course is going to start tentatively in September, and it is the Fundamentals of Critical Care Nursing course. And this is designed for nurses that have more than 1 year of critical care experience at least, and it is a comprehensive approach to critical care nurses. I know many of you have been waiting patiently for the, I apologize for my phone, I just shut it off, patiently for the interviews, and those are about to start next week. Next slide, please. So let me take you a little bit through the journey of Mrs. N again. She started with a DKA and came into us not looking too well, but ill enough to catch our attention, luckily. And she ended up in the ICU. She then had acute respiratory distress syndrome. She was intubated and ventilated. She went on cardiovascular support. We thought we were doing okay with her, and we tried to extubate, but then she failed extubation, and then she ended up with a tracheostomy. So there she is with a tracheostomy, and I will ask Dr. Mohsin to begin with the MCQs. One message that I would like to convey to our critical care nurses that I have always said to all my students when I've taught them is that one thing you have to remember in critical care, what is critical, is time. And Dr. Mohsin, when he talks to you, will talk about that at the end again when he summarizes sepsis for you.
Wonderful.
Thank you.
Welcome, everyone. I am going to go through the wonderful work that all our presenters have done, and we are going to focus on the key messages we were hoping you would have acquired during those sessions. So we are going to make this very much about MCQs. We are going to look at how you respond, and if the response, we are hoping the responses would be wonderfully correct most of the time. And if not, we will then try to address what might be the reason for any confusion. So without further ado, this is your first question. Which of the following is an aerosol generating procedure? You need to know that, of course, because you need to decide what kind of PPE you're going to put on. So we'll give you 60 seconds to answer. The timer is not showing up, Waleed. Is it can you guys see the poll?
Yes, we can see the poll. I can see it at least.
I'm just saying because nobody has responded yet. Usually we get lots and lots of.
I see the question. I didn't mean I can see the question. So maybe they cannot see it. Waleed,
people are responding, I think.
I can see. Okay. I can't. You see, normally I see the poll changing as to with the response.
Okay. I can make you a poll. Wait.
Okay.
Yeah, people are responding because they're messaging us that they're responding.
Fine. So, Waleed, whenever you can make it. I can see it now.
Yes.
So, Okay, the answer was CPAP. The correct answer was CPAP. A lot of you thought a simple face mask would generate aerosol. Uh, that's not entirely true. A face mask is not an aerosol generating procedure because the flow rates are not high enough to do that. Venturi devices, you're correct, absolutely, are not aerosol generating, and neither is a nasal cannula. But the right answer was CPAP, and 8% of you got that right, which is kind of worrying. So we go to the next one, which is the ABCDE approach. And stop sharing, go back. What does C stand for in the mnemonic ABCDEF approach from the first talk, which was about initial assessment? So your choices are carbon, clinical, circulation, and confusion. And it's wonderful to see that the response is 100% correct at this point in time. Oh, fun. Somebody thought carbon. Okay. I'm going to assume whoever has written carbon as the C is just pulling my leg because the rest of you have got it right. And it is circulation, yes. The next one is assessment of cognition. Now, just going to share that result with you. Oh, somebody put in confusion as well. That was not the right answer there. So which of the following is used to detect delirium? There are several things we talked about early on in the courses, and there were different methodologies of approaching it. What we identified was that a lot of you were using GCS as a means of identifying confusion. And there was a question about it later on, which we then clarified is not the way to assess delirium. Okay. So let me show you the results. As you could see, GCS is not the right answer. The right answer here was 4AT. Even the RAS is not designed as a means of picking up delirium. Your RAS will change with delirium. Certainly agitation and confusion can change your score, but it's not there to pick it up. A GCS, if used as a tool to pick up delirium or confusion, it's a very crude tool which will miss more than 60% of those with delirium if you were to use it. On the other hand, if you were to use 4AT, you will pick up 9 out of 10 patients who have got delirium. So the tool to use is 480, which is only 2 points. And there should be a copy of that in your handout. Or if not, then I'll make sure it's in the shared resources. Did anybody want to say something?
No, that's fine. Go ahead.
Cool. So assessment so this can have multiple answers. Mrs. N's vitals show a heart rate of 92, a respiratory rate of 24, temperature of 35.7, blood pressure of 102/44, and as for cognition, her 480 has come back positive. So which of these is worrying? The heart rate, the respiratory rate, the temperature, the blood pressure, the decreased cognition, or all of them? I haven't put the, so I don't know. Can you guys point on multiple things? This was designed for you to tick as many things as you think are worrying. I suspect that given people are not doing that, that they can only tick on one thing. Well, the correct answer here is that all of them are worrying. A heart rate above 90 should worry you. A respiratory rate above 22 should worry you. Temperature below 36 degrees should worry you. Actually, yeah. And a blood pressure where either the systolic is less than 90 or a diastolic is less than 50 should worry you. Okay. And of course, cognition being deranged is again a worrying sign. So all of those were criteria at which you should start considering that this patient needs urgent fluid resuscitation or might be septic.
Yeah, and I'm glad that if they could only pick one, they picked the cognition. That is very important.
Yes. Which is very, very true. So that concludes the questions about the first talk, and we are going to move on to the second talk. And humidification was one of the things we covered. So as at what flow rate from a nasal cannula does the patient usually start complaining of dryness? this was interesting because we got a few questions about it and we clarified the thing. And I could see somebody has put down 10 liters, somebody has put down 4 liters. I mean, 6 liters, 10 liters, 6 liters seems to be the. So see, it's not asking you what's the upper limit of flow. It is asking you when does the patient start complaining that my airway is getting dry. Yeah. Fine. Okay, let me share the results with you. As you can see, the right answer actually was 4 liters. So anything beyond 4 liters, the patient will start complaining that the airway is getting dry. And that was the question being asked, rather than how fast can you give, at what flow rate can you maximally give air through a nasal cannula, for which the answer would have been 6. Okay. So next one. What amount of FiO2 should a patient suffering from COVID pneumonia be offered awake proning? So awake proning was one of the things which came along when COVID came to us. This was one of the things we covered. And the idea is to see at what FiO2 should you trigger. Ah, wonderful. Oh, okay. The first person got the answer right, and then somehow things changed. Okay. So it's a nice little spread all over the place here. But the correct answer is 28%. It is 28% FiO2 at which you should be offering the patient to prone themselves. Okay. And that is based on the guidance which came from Intensive Care Society of UK. The next question is, which of the following is true about CPAP? And one of them is, of course, true. The rest are false. It decreases the work of breathing. The pressure goes up when the patient is taking a breath in. Should be given to all COVID patients on oxygen. And patients cannot be offered awake proning if on CPAP.
Mohsin, may I suggest that you also put all these questions in the resources, because it's a learning exercise. We are not testing them on this today.
Which is absolutely fine. I can certainly do so. And I'm so glad to see that in this case, most people got the answer right, which was decrease the work of breathing. The pressure remains constant in CPAP. We don't have two different levels of pressure. So it doesn't change when somebody is taking a breath in. So, i.e. the machine doesn't push air into the lungs. It keeps that push constant throughout the respiratory cycle. And somebody should be given to all patients on oxygen. The answer is not really true. Their FiO2 has to be above 40% before you would consider it. And patients cannot be offered awake proning if on CPAP. That is untrue either, because again, CPAP should not be a reason why they cannot prone. As a matter of fact, we judiciously on my unit prone people on the HDU while they are on CPAP because it does help. Okay, so that's that. We go to the next one. So now questions from the third talk, which was again done by Prof. Jaffer and Nasreen. And this was focused on acute respiratory distress syndrome and proning of a patient who's intubated. So oxygenation devices was one of the things we covered here. So in a patient who's saturating 90% on 6 liters of oxygen via nasal cannula, what is the next choice of oxygen delivery device? Because your target, of course, in a normal person is above 90. So would you now put them on a face mask, a non-rebreathe mask, CPAP, or just put an ambu bag on? And I'm so glad to see that most of you are getting the answer right. As a matter of fact, all of you have got the answer right at this point in time. Okay. Somebody wants to put a non-breathe on, rebreathe on. But 80% of you have got the right answer, which is that it should be a simple face mask, which is the next step in your oxygenation tree. Okay, we move on to the next one. ARDS is acute respiratory distress syndrome. Which of the following does not cause ARDS? And we're talking about pulmonary embolism, sepsis, pancreatitis, deperfusion syndrome, burns, or cardiogenic pulmonary edema. So which of these does not? I'm again saying focus on the not rather than what does cause pulmonary ARDS. Okay. Okay. Most of the answers seem to be suggesting everybody has picked up all the causes of ARDS, and we have 0% for the only thing which is not cause of ARDS, which is cardiogenic pulmonary edema. It's in the definition that it's in the exclusion criteria. But everything else, just so you know, pancreatitis is one of the most common causes of developing ARDS. As a matter of fact, there's some new guidelines out which suggest that the liberal fluid administration, which used to be part and parcel of management of acute pancreatitis, should be reviewed because they identified that the liberal fluid management increases the risk of these patients developing ARDS. Yes? So just keep that in mind. But sepsis causes ARDS. PE, especially if associated with pulmonary infarcts, causes ARDS. Reperfusion syndrome does present as ARDS at times, and burns can cause ARDS. So there are quite a few things that can cause ARDS. The only thing which doesn't cause ARDS is cardiogenic pulmonary edema, which presents as if they might have ARDS on an X-ray, but it's not that. So the next question is proning in a ventilated patient. Which of the following is a contraindication to proning in an intubated patient? So what you're saying is you've got a patient intubated, you're thinking about going ahead and proning them. What would be a reason not to do it? Okay. Oh, this is very, very encouraging. Okay, 30 seconds are done. And what we know is this, that most of you got the answer right, 75%. The third trimester of pregnancy is a contraindication to intubated patients being prone. A mean arterial pressure of less than 65 is one of the concerns you have. It's not an absolute contraindication, but you do become quite a bit more wary if they're hemodynamically unstable to prone them. And some units would not do it. Just keep in mind an FiO2 above 65%, at least in quite a few units in the UK, is an indication to start proning these patients. So an FiO2 of 80% certainly would fall in the bracket of those who should be offered proning. Okay. Next slide. And of course, then we go to the fourth talk, which was about invasive ventilation. This was delivered by Dr. Ahmed and Shabana Ali. You'll find Shabana did quite a few of these talks with us. And thank you again for Dr. Ahmed. He's joined us today, I believe. Invasive ventilation is what we are going to talk about. So which of the following is the most commonly used mode of invasive ventilation? And we are just giving you 3 names here because I didn't want anybody confused. Go ahead. That of these 3, which is the most common used mode? Okay. Okay, so more than half of you have got the right answer. It is SIMV. CMV is not the most common mode, at least on critical care units, and APRV is again used in patients who have either got ARDS or pulmonary edema. So the right answer was B here, or number 2. Moving on. Which of the following is not a complication of invasive ventilation? Now, I believe one of you asked the question earlier on today about proning and raised intracranial pressure. We will talk about that in a sec. But, wonderful. Okay. So, given the fact that it started very promisingly and it has now spread all over the place, I'll tell you where the problem lies. Most of you got the answer right, which is the high blood glucose is not a complication of invasive ventilation. Hypertension happens because when you start to invasively ventilate somebody, you're putting more pressure in the thoracic cavity. So whatever is outside of the cavity has to work harder to get in. i.e. the pressure has to go up. That means that your blood pressure, if you don't have enough volume in you and the chest pressure has gone up, your blood pressure would go down because there won't be enough blood coming to the heart to pump enough through. So it causes hypertension. If you put in lots and lots of pressure, just like with a balloon, you can actually cause a hole in the lung itself. So you can cause an pneumothorax. Anybody who's invasively ventilated cannot clear their own secretions. You have to put tubes down to do it. And so there is a much higher risk of developing pneumonia. As a matter of fact, it's one of the most common reasons that people who are given ventilation for a long period of time end up having an infection. And the raised intracranial pressure, what happens is that since there's increased pressure in the thorax, your venous pressures go up as well. And so since your venous pressures have gone up, your intracranial pressure corresponds and goes up. So the same thing happens with proning when somebody is prone, that the intrathoracic pressures go up, and again, the intracranial pressures can go up because of it. Okay, the last question about ventilation, I hope. You're doing your nursing checks and you want to know if the tidal volume is appropriate for your patient. Now take your time with this. You can take more than 30 seconds to answer. What process would you follow? Would you weigh the patient and multiply whatever number you get by 6? Would you weigh the patient and multiply that answer by 10? Would you just write down the tidal volume you see on the ventilator and that's about it? The number really doesn't matter. Would you measure the patient's height, calculate the ideal body weight in kilograms, and then multiply that answer by 6? Or again, the same thing, measure their height, calculate their ideal body weight in kilograms, and multiply that answer by 10.
Yes. And Mohsin, your slide says 8, but I think you mean 10.
Fair enough. Yes. So where it says 8, please, I apologize. It actually means 10 there, not 8. Okay, so we've given this almost a minute. So we will stop now. And again, it's wonderful to see that most of you got the right answer, which is that measuring the height, and from that height, you calculate the ideal body weight in kilograms. And when you get that answer, you multiply it by 6. That is the target tidal volume. And if your patient is getting much higher volumes, then you have to really think that should the pressure be changed, or that you might be causing trauma to the lung by giving such high pressures. The weight itself has no value because if somebody is really, really fat, the lungs don't grow with it. And again, if you're very, very thin, your lungs don't shrink either. So your weight actually by itself has no value in this calculation. It is your ideal body weight which matters. And of course, it's not a good idea to just write down the tidal volume and leave it alone. You're looking after this patient, and we should be avoiding harm at all costs. Okay, then we come to the 5th talk, which was vasoactive agents and nutrition in critical care. Again, Shabana kindly talked along with Mehek, and we are going to go ahead and ask those questions. In sepsis, which is the first choice of vasopressor? So is it adrenaline, noradrenaline, dopamine, vasopressin, or dobutamine? So if somebody comes onto your unit and they need some kind of a medication to be started so you can bring their blood pressure up, what would that be? So noradrenaline is the same as norepinephrine, in case that's what you call it at your unit. Okay. Well, some of this is very, very encouraging. Almost half the people thought that noradrenaline would be the first choice, which is true. They are correct. Dopamine, some units don't use dopamine anymore. I suspect I'll be surprised if any do at the moment. Adrenaline is only a drug of last resort if other things don't work. Vasopressin has got its own indications, but it's not used as the first choice drug, which is what the question was. And again, dobutamine is used in patients with heart failure, but without heart failure, again, this is not the first choice of vasopressor for sepsis. That was the question, and the answer is noradrenaline. Which of the following medications does not cause a fall or a decrease in blood pressure? And the answers are dobutamine. So we are asking for those which does not cause a fall, not the ones which do, but the one which does not. Okay. Okay. I should have highlighted the not here because people have said yes to all the drugs which do cause a fall in blood pressure rather than the ones. Uh, uh, so if you were to answer which of these does not decrease the blood pressure, it's epinephrine. Epinephrine always increases your blood pressure. All the other four, lisinopril is an antihypertensive. Its very job is to decrease the blood pressure. Dobutamine again causes the heart to constrict more more forcefully, but it can drop your blood pressure. Dexmedetomidine works on the same receptors that clonidine used to work on, and clonidine in the old days was one of the treatments for hypertension. Yes. So again, the right answer here was epinephrine, and propofol again causes a drop in blood pressure. So the next question is sedation. Which of the following is not a common side effect of benzodiazepine infusion? So we're looking for what is not a common side effect, because some of these are common side effects of somebody getting a benzodiazepine. Okay, wonderful. I love the answers coming as they are. And my enthusiasm was short-lived. Okay, well, the good thing is most of you got the answer right, that seizures is not a side effect. It's one of the treatments for benzodiazepines. I mean, benzodiazepines are used as one of the treatments for seizures. Excess sedation is fairly common in the elderly secondary to benzodiazepines. That's one reason why a lot of units in critical care have moved away from benzodiazepine infusions completely. Like in my last unit, if you wrote a benzodiazepine infusion, somebody came to look for your head to chop it off. That why have you written this? Yes. Similarly, weakness is a common complication seen with long-term benzodiazepine infusion. Cool. Then we go to the sixth talk, which was thanks to Mehreen and Zahira. We talked about liberation from ventilation. And here's the first question. Which of the following is not a contraindication to weaning? Yes. So most of them are going to be contraindications. Mehreen had a wonderful slide on this, if I remember right. What we need from you guys is the answer as to which is not a contraindication to consider weaning. So I can tell you that wheeze is a contraindication. Ongoing sepsis, again, is a contraindication. And so is patients with ongoing pulmonary edema. All of those were contraindications to somebody being, where you start thinking, let's start weaning them. You need to address the primary cause of the problem, which might be contributing to hypoxia before you do that. The right answer was intubation in the only intubated for only 24 hours. So the idea very much being that once you've been intubated for 24 hours, you need to start thinking that should we be weaning them now?
Mohsin, the perfect example is a post-op patient,
Yes.
who's come in for like a gallbladder. I mean, you intubate them, but then you have to wean them off as quickly as possible. So that's not a contraindication.
Can I inject something? I think
Please.
Looking at the answer, I think the negative questioning has some issue, it seemed like. I think the people knows this thing,
Yes.
but I think it's
I
a
agree.
training. I remember myself during taking the first exam like this, a long time back. It's always a challenging thing to answer and understand the question when this is a negative thing. So I don't think the audience are not aware of the facts. Probably it is the way we are asking the question.
No, you're absolutely right. The negative questions do make, like very idea is it pushes them into thinking rather than automatically answering the question that I know this. So the idea very much is to make them stop and think. But I totally agree with you. The chances of people answering incorrectly is much higher in a negative patient.
Good thing is we are not grading
question.
them, and they will have all these questions as resources later.
Exactly. Okay, liberation from ventilation. Which of the following indicate that the patient is not ready for extubation? Again, I apologize for the negative question already.
Maybe, Mohsin, if you go over each item and ask them yes or no, then they can think through it, you know.
Fair enough. So what you're thinking is, which of these is, sorry, let me go back. Which of these indicate that the patient is not ready for extubation? So what you're saying is that patient develops a respiratory breathing distress when you put them on a spontaneous breathing trial. So should you really be thinking about taking out the ventilator completely? The answer is that really an indication that this guy is ready or that this guy is not ready? Yes. The next question, of course, is respiratory rate is only 12. He's got a good ability to cough, and FiO2 is less than 40%. And I'm so glad 75% of you got it right, that if they develop respiratory distress during spontaneous breathing trial, do not try to wean them or liberate them.
That was taught right.
Cool.
That was taught right.
Yes, yes, that was taught absolutely correctly. So what proportion of patients extubated will fail the procedure? So even if you do everything right, how likely is it that things will go wrong? Okay. And of course, the reason why we are asking you that number is to figure out that this is the risk I'm running. So what do I need to do to mitigate that risk? Not to say that once you've mitigated all the risk factors, the patient still won't fail. They might do. But the idea is that this is the risk. Just keep in mind, if anybody fails an extubation and they have to be re-intubated, the risk of mortality and long-term illness goes up quite significantly. So it's a very important part of what's going on. And the right answer was 1 in 7. Okay. So if you're only getting 1 in 25, somebody's ventilating a bit longer than they ought to, or you're being too cautious or doing ventilation for too long. Similarly, 1 in 50 is a ridiculous number. 1 in 3, you're extubating too early. 1 in 15, again, you're taking longer than you ought to. The right answer is 1 in 7. And those numbers are important because it gives you a rough idea of how frequently to expect a problem. And if that problem is happening less frequently, you start thinking, is there a problem with my own practice? In which of the following conditions would you offer NIV post-extubation to prevent failure of extubation? So you have gone ahead and taken somebody's, or you're planning to take somebody's tube out and let them breathe by themselves, but there's a particular population where you have to go ahead and say, actually, if I put a tight-fitting mask on and give you some ongoing positive pressure, you're less likely to end up needing for me to intubate you again. And the answer, of course, is pneumonia, COPD, bowel surgery, head trauma, or patient on dialysis. So
this
would
is a
you
tough
give...
question for them.
Sorry?
I said, this is a tough question for them.
Oh, okay. I apologize.
No, that's okay, but it's a learning one. It's
yes.
a learning one.
And the wonderful thing is most people did get it right. That
Yes.
COPD is the right answer. That these patients ought to be offered NIV post-extubation. So you all got it right. Head trauma is certainly not one of the reasons why you should do it, and patient on dialysis has no implications, or at least should not have an implication for your extubation strategy. Pneumonia, again, should have resolved, and if you have extubated somebody and put them on an IV, I would probably argue that you have extubated them earlier than you should have. Now comes the last talk, which was tracheostomy. This was done by Dr. Rouge and Shahroz, and it was a wonderful talk. I did get a chance to attend all of it. And they talked about tracheostomy. All the following are different types of tracheostomy tubes except. So Dr. Rouge discussed these with you, and she gave you a couple of slides talking about what are the different types. And wonderful. Okay. So of course, again, this is a play on the not thing where we are asking you for the negative thing. So what you're thinking through is cuffed a type of a tracheostomy tube? Is uncuffed a type of the tracheostomy tube? If they are, then that's not the answer. Fenestrated, if that's a type of a tracheostomy tube, that's not the answer. If angled is a type of a tracheostomy, it's not the answer. If curly-whirly is type of a tracheostomy tube, then that's not the answer either. Most of you got it right. There's no such thing as a curly-whirly tracheostomy tube. If there was, it will look wonderful and strange. But the rest of them are different types of tracheostomy tubes. A speaking valve only allows inflow of air through the valve during inspiration and blocks the outflow through the valve during expiration. So if you remember that we were talking about speaking valves with tracheostomy, and the question is basically asking you, is this statement true or not? And I am glad to say that most people have got the answer right. Yes, this is a true statement. That is what a speaking valve does. It only allows flow of air through one direction, which is from out the environment into the patient's body. Doesn't let the air go out through the same hole though. So next question, safety checklist of transfer of care. So we are talking about a patient with a trachea and you have started your shift. Somebody is coming to you and saying, okay, let's do a handover, a nursing handover, and you have to ask them questions about that tracheostomy. So what we are asking you is, which question is not part of that list that you would ask? Ah, wonderful. The person who has given the first answer is absolutely correct. And then the game begins. Okay. Fine. Okay, the correct answer here was the date of admission to hospital is not part of that handover. But you need to know what type and time of trachea, what type of trachea it is and what time it was inserted. Even if it was inserted a week ago or 2 weeks ago, that is implications for how well the stoma might have formed or how likely the stoma is to close if this is an emergency and it's not really there for a long period of time. The reason again is important because it gives you an idea of what was the problem and is that problem getting better or not. And airway is an issue, especially the questions like, are they bringing lots of phlegm? Are they able to cough it up? Because that has implications of what happens if during your shift, the patient starts to desaturate. If the nurse before you tells you, actually he was coughing up lots of thick phlegm and it was taking quite a bit of difficulty to aspirate and he's now dropped his saturations, that might be one thing you consider. Cuff pressure is again important. If you do a CO2 trace, you should be having capnography attached. But cuff pressure tells you that if it's too high or too low, that there might be something wrong. And who to ask for help is one of the essential bits of your handover. You do need to have a clear idea of who is the person that you need to call. Is it an on-call person or an on-call number? But you need to be very clear in your handover who that is going to be for your shift. And the date of hospital admission, as we said, is not really needed. The next question is emergency tracheostomy management. When concerned, take the ABCDE approach where it stands for airway, breathing, circulation, disability, and exposure. True or false? Waleed, if you can put the question up. Hello? Waleed?
Actually, I don't have this question.
Oh,
You didn't send
I
me.
apologize. I don't know why that happened. The answer is that it's true. Waleed, have you got this question?
Yes, I have.
Okay, fair enough. So in an airway emergency, this is based on that flow chart that you guys went through. In an airway emergency, in a patient with tracheostomy, which of the following is true? And of course, answer, it's only going to be one of these which is true. Okay. Apply high flow oxygen to the tracheostomy only. So what you do is you put high flow oxygen at the neck, but don't do anything with the face. Call for help only if the patient sats remain below 80% after you have done everything you could think of. So what you're really saying is that the patient has a tracheostomy, he has become quite hypoxic, but let me do everything I can do by myself before I ask for help. Take out the tracheostomy at the first sign of distress. Block the tracheostomy with your finger and put a face mask on the patient. and call for expert airway support early. The correct answer was call for expert airway support early. It's a tracheostomy. So you should be thinking that whoever needs to be here who can deal with the tracheostomy needs to be there right away. You don't want to wait around and find out that things have gone badly wrong. Similarly, the worst answer you could choose is to keep on doing things all by yourself while the patient is significantly hypoxic. So answer 2 was some kind of an option you should never click on. High flow oxygen to tracheostomy again is the wrong answer because you should apply it both to the mouth and to the neck. If you remember the video which we showed, the second person who was called in early did exactly that, asked the first person to put it on the face as well. And you should never block the tracheostomy with your finger in this situation. You should put oxygen on. As a matter of fact, if they've got a speaking valve, you should take that valve off. And if they've got an inner tube, you need to think about taking that inner tube out as well. Okay, now we covered a lot of things in our sessions, but sepsis was not focused upon. It's one of the most common things you see as a critical care nurse. So we are going to talk a little bit about it. And here's the key to it, that most of the time somebody decides sepsis because the blood pressure is low, they have gone into shock, the multiple organs have stopped working, or their clotting has become abnormal along with fever and infection. And we frequently focus on the acute phase, the first 6 hours of antibiotics, fluid, and everything else. The reason the slide is there is to identify the fact that all that's happening in the beginning is because of association with the cytokine release storm that they talk about with COVID. So just keep in mind that that's not only true for COVID, but can happen with a lot of other conditions. And then there's a chronic phase, which is frequently seen in patients who come to critical care, where the inflammation doesn't actually resolve completely, but they end up in a chronic immunosuppressed state and end up picking up secondary infections. And these patients you have to be really careful about, because these are the people who will need some kind of follow-up support. They will need to be reviewed on a later date and will need support to get back into a working life, or they will end up just getting secondary infections, long-term mortality goes down, and they will die in a short period of time. So about sepsis, when do you start thinking about it? Anybody who's got a fever and says they're feeling unwell, you should start thinking, could this be sepsis? And then you focus on those who are elderly, i.e. above 75 years of age, or those who are young, those who do not speak the same language as you, or don't have the same first language as yourself, or they've got other communication problems, like somebody's got dementia or something else going on with them. There are 6 things to look for. And in this case, what you have to think is, what is the high risk bit and what is the moderate risk bit? Yes, and we will go to that in a second now. So you have to think about their history and behavior. If they have had a procedure done, or they've had a trauma in the last 6 weeks, if they've got any reason to have an impaired immune system like cancer or immunosuppressive drugs, or if their functional ability has deteriorated, or last but not the least, if either they or the relative says that he's not as bright as he normally is, that should start ringing alarm bells for you. Now, when it comes to breathing, anybody with a respiratory rate above 25 should be raising alarm bells. So it's a red flag as far as you're concerned with sepsis. On the other hand, a respiratory rate between 21 and 24 should still concern you, but it's not raising a red flag. Keep in mind, anybody who ends up needing oxygen more than 40% to have saturations above 92, this is a red flag for you. Even though you have achieved that goal, the fact that you have to give more than 40% oxygen should worry you. And for a COPD patient, that target is 88. Similarly, always look at their skin, looking for any evidence of any focus of infection. Look at their circulation. A heart rate above 131 is a red flag. And anyone above between 90 and 91 and 130, again, is a red flag for you. Keep in mind, a pregnant woman, the number changes from 90 to 100 to 130. Yes. And anybody who develops a new AF or a new arrhythmia with an acute infection is at higher risk of dying, especially if it's atrial fibrillation. Now, temperature is important. We all focus on temperatures above 38 or 37.6, but the key here is remember the temperature above 36, below 36 degrees, because that is a concerning thing for you. And urine. It doesn't matter whether you have dipped the urine or not, because fair enough, it has poor yields. But remember, you need to ask if they have passed any urine in the last 18 hours or not, or if they passed any in the last 12 to 18 hours. And if the answer is no to either one of them, you are really concerned about them. And here's how you will approach the problem. If any of these things is in red, you're going to go ahead and say the patient has fever, he meets one of the serious criteria of poor outcome. I'm going to start sepsis management. You're not going to wait for investigations. You're going to make sure they get antibiotics within 60 minutes of your initial assessment. And then they need repeat obs every 30 minutes. And the doctors need to take the blood tests within that first hour. And part of that initial investigation has to be lactate. And if the lactate is above 2, then you go back to the fact that, of course, you're continuing with your regime. If they put up any either 1 or 2 markers in the orange zone, where they're high risk, again, they should have those blood tests done right away. And one of the first things you should be looking at is the lactate. The clinician should review these patients within 1 hour of presentation. And if the lactate is above 2, then you go back to the red signs and start going ahead and giving them the antibiotics. The next thing is fluids. All these patients who are red flagged should have fluids offered to them, no questions asked. And if they're in the orange bit, then again, they should be offered fluids for resuscitation if their blood pressure is low or heart rate is high. Keep in mind, a bolus is defined as 500 ml of fluid given over less than 15 minutes. So putting up a bag over 3 hours, 4 hours, or 2 hours is not what we are asking about here. We are asking them you to make sure they get half a liter of fluid very rapidly. Okay, and now that my bit ends, I'm going to hand everything over to Shabana.
Well, thank you so much, Dr. Mohsin. That was a really good summarization. And here comes the nursing part. I'm just here to discuss about what is the future of nursing, critical care nursing. So before I do that, I really want to share that when after the graduation, if a nurse is intending to become a critical care nurse, of course, she would join the ICU, the basic nursing degree that we all got. I got my degree from Pakistan as well. So when I did my diploma, I was a nurse as all of you are. But then my intention was to go for a critical care nurse. So I joined a critical care unit. And then from there, my journey started. So here, while I migrated from Pakistan to US, so they have a pretty good scope of a critical care nursing. When a nurse enters a critical care nurse, it can be ICU, it can be a CCU, it can be even ER. She underwent a kind of a rigorous program of teaching, a rigorous program of orientation that includes classroom-based teachings, that includes the competencies, that includes the skills lab. And there is a pretty good orientation manual that a nurse goes through for 6 months to become accepted in this field of nursing. Because when we talk about critical nursing, we are talking about kind of high-tech level of care for critical patients who are having a multi-organ failure, who needs ventilators, who need medications, drips, that needs high level of assessments and care. So once you attended those orientation and you go through a rigorous process of a continuous education and continuous skills. Here in US, we have a body which is called AACN, which is a critical care nursing body. So we get membership of that American critical care nursing. So we become the part of the critical nursing society in America. So the idea is we need to develop those kind of nursing bodies in our countries, so all the nurses who belong to that particular field of nursing come unite together, talk about their issues, talk about issues I'm talking about from nursing care, from education. Is there is anything they need to learn? Is there is anything new coming in the medicine and they want to learn about it? Some drips, some procedures. So those kind of things are discussed in those under the umbrella of those critical societies, and then nurses come together, they teach each other, they help each other, they help in promoting those protocols, they share their best practices that they are doing in their own hospitals, and they make it a part of evidence-based practice, so everyone can refer, and if everyone can implement that. So this is something really important. How the American critical care nursing came into being. There were just a group of 20 to 25 nurses who just one day decided that we need to learn. We need to learn more beyond what we are doing, because we are working in the critical care unit. We are being dependent on the doctors. We should be able to make some critical decision while we get the help, while the doctor comes on board or physically comes on the floor to help us. So what they did, all these 20, 30 nurses came together, they sat down and they started talking about it. They did some seminars, other nurses joined them, and today this nursing has more than I guess thousands of nurses in under that umbrella of critical care nursing. They every year they do seminars, webinars, they have their own web page. We can always go and refer. So the idea is that if we really want to grow into this practice, critical care nursing, we the nurses need to come forward. Yes, we need to be under the umbrella of our state nursing board, but this initiation needs to come out of us, that we need to learn, we need to increase our scope, we need to learn more from others, and we need to share what are the issues in ICUs, what are the issues in CCUs, what kind of things which is our scope of practice and we can do it, and what are the things which we cannot do it, which is not in our scope. So those kind of things should come out from the nursing to initiate, become a group, become a body, come under the umbrella of the state nursing, and then you go from there. So here the same situation, every critical care nurse is the part of that, and it's not just making a group, it's not just making an organization, it's a continuous learning process. If I am a part of a critical care nurse, every 2 to 3 years I have to retake the exam to be a live member. So that means I am on a continuity of learning, I'm in a continuity of my practice in order to be a critical care nurse, which is very, very crucial. Not just getting a license or certification one time and then you shut down your books and everything. No, things are changing rapidly, like the COVID. When it came out, critical care nursing boards became an active member with WHO and everybody. They gave us the new processes. They gave us the new process of doing things like intubation, PPEs, and all that. Major changes came out, but not just from the WHO, but from the nursing body, the critical care nursing body as well, as an alternative process, keeping the core nursing curriculum, the core nursing practices in mind. What could be the alternative way of caring those patients? So from there, it's just a fruit of thought from me to you all, being a critical care nurse, that I really want to see this kind of scope coming in from Pakistan as well, where all the nurses were so bright, good future, and we can come up with some kind of, and I think APPNA, under the banner of APPNA, this is really a good initiative of initiating this critical care course. Maybe from that course, we can move forward and do these courses repeatedly, so we have a good group of nursing, bedside nurses. I would really emphasize on bedside nursing, because these are the core people who are taking care of those patients. Yes, our leadership and management always welcome and be the part of that, so they know the process, so they can help those bedside nurses implementing and remove the barriers and hindrances to practice those nursing processes. So with that, I'm gonna have Rafat Jan to talk about and see where our future of nursing in critical care aspect in Pakistan.
Thank you, Shabana, and thank you, Dr. Mohsin, Dr. Noormahal. First of all, I like to congratulate all of you. Today, Dr. Shahid, Dr. Danish, and myself, we are extremely, extremely happy and satisfied. We started our journey not even thinking of critical care, but with APPNA. This was one of my dream which I discussed with the APPNA Merit co-chair, and I'm so glad they accepted my request. And today we are reached at this point. Almost 8 webinars took place, and this was a real collaboration. I'm extremely thankful to in medical team, Dr. Noormahal, Dr. Mohsin, who were present in each and every single webinar, and Shabana. You are the role model for nurses. You were present in all the webinars. And I have probably, I'm not taking name of all medical and all nurses who were presented, but I'm extremely grateful to Dr. Kaleem Ahmad is here, Dr. Jaffer, and so many nurses who really gave these presentations and enhanced our learning. As you said, Shabana, we have to work now towards specialty groups. If we are not going to work on specialty groups, we are not going to move on. And then within these specialty groups, we have to increase our competency. We have to maintain our competency-based license renewal. And these are some things where we have to go. I'm hoping, and it is my dream, that in Pakistan, although now nurses have been aware of higher education, but with this higher education, we go for clinical based education, whichever population needs it. So this is my dream, and today, Shabana, you have mentioned very important point for moving forward in profession. As with APPNA Merit, now future is this, after these webinars, there will be critical care course, and few people in each batches are going to take this course, and inshallah this will bring best practices for our patients, and inshallah this will bring best care for our patients. So we are extremely happy. I'm also grateful to Walid because all the time, it's not just for these webinars, but I have been each and every time for conducting meetings for us, for reminding others. So he's all the time put him forward. Inshallah, with Dr. Shahid and Dr. Danish Merit team, like you are moving with the medical and nursing team in the critical care, and you are critical care group, we will be doing other things as well, and other specialty as well. And working together in a team, that is our dream. Pakistan has to change, and nursing will earn respect and honor through our bedside care, through our patients, their family, and community. Once again, I congratulate each and every one of you. Each and every one of you. I'm extremely grateful to all of you. आप सबको बहुत बहुत मुबारक हो, और आप सबका बहुत बहुत शुक्रिया. और अगर मैंने किसी का नाम ना मेंशन किया हो, तो प्लीज़ आप मत सोचिएगा कि we don't know these names. We know. Thank you so much, and inshallah we will be connected together. Thank you so much. Dr. Shahid, I would request Dr. Shahid, Dr. Shahid as a coach, in fact, founding chair of Merit, he speaks now.
अस्सलाम वालेकुम, बहुत शुक्रिया रफत आप के आने का, और जैसे आपने जिक्र किया कि ये हमारा सफ़र मार्च 2020 जब हमने एक फैमिली प्रैक्टिस की कॉन्फ्रेंस की पाकिस्तान में, तो हमने ये सोचा कि लाजमी है कि एक सेशन पूरा जो है वो नर्सिंग पे होना चाहिए, क्योंकि आप लोग जो पाकिस्तान में हैं, शायद जाहिर है अगर बाहर नहीं आए तो आपको शायद अंदाजा नहीं कि यहाँ पे कितना नर्सिंग जो है वो एक ऑनरेबल इम्पोर्टेंट प्रोफेशन है, बहुत competitive है, especially then when you go into subspecialty like critical care nurses and ER nurses, they are really top of the line. और जो स्ट्रक्चर है और जो कल्चर है वो ऐसा है कि यहाँ पे जो है हेल्थ केयर जो एक पेशेंट की है वो एक बहुत बड़ी टीम करती है, और उस टीम में आप सोचें कि 8 से 10 लोग हो सकते हैं, उसमें डॉक्टर सिर्फ एक है, और तो यही सोचें कि रियली उसका अगर हाफ नहीं 1/10 नहीं तो हाफ से ज्यादा उसका पोर्शन नहीं है, क्योंकि उसमें नर्सेज का बहुत बड़ा पोर्शन है, क्योंकि नर्सेज जो हैं डॉक्टर आके डाउन करके चले जाते हैं, डॉक्टर्स अपने ऑर्डर्स लिखते हैं और डिसीजन करते हैं, which is important of course, I'm not saying that, but taking care of the patient is not just giving them medicine or deciding what medicines they should take or what is the diagnosis of. That's a big important part. But the care of the patient and healthcare is not just that. उस केयर में ये आता है कि वो जो पेशेंट एडमिट हुआ है वो 2 दिन रहता है, 6 दिन रहता है, 10 दिन रहता है, वो कैसे वो मजीद खराब नहीं होता है बल्कि अच्छा होता जाता है और बतदरीज वो डिस्चार्ज होता है अच्छे सेहत के साथ। सो उसमें नर्सिंग का बहुत बड़ा रोल है। उसके अलावा उस टीम में फार्मासिस्ट हैं, फिजिकल थेरेपिस्ट हैं, डिस्चार्ज प्लानर हैं, सोशल वर्कर हैं, यहाँ की मैं बात कर रहा हूँ, तो वो एक बड़ी एक टीम है। सो अनफॉर्चुनेटली जो भी कह लें, मैं समझता हूँ कि रिसोर्सेज से ज्यादा ये विल की बात है, एक दिल की बात है कि आप समझें इस टीम को, जहां पे भी, चाहे वो पाकिस्तान है या कोई भी मुल्क है, आप इस कॉन्सेप्ट को समझें कि ये जो है एक टीम एफर्ट है। पेशेंट को ठीक करना, हेल्थ केयर, प्रिवेंटिव केयर, पेशेंट्स को हेल्दी रखना, उनको ये कोशिश करनी कि वो दोबारा वापस ना आए हॉस्पिटल में, दोबारा रीएडमिट ना हो या एडमिट हो ही नहीं। जो प्रिवेंटिव केयर हैं, जो छोटे छोटे अच्छे उसूल हैं सेहत के, उसको हम कैसे फॉलो कर सकते हैं, ये नर्सेज करती हैं और नर्सेज ज्यादा बेहतर तरीके से करती हैं। तो जो प्राइमरी केयर नर्सिंग है, पब्लिक हेल्थ, कम्युनिटी नर्सिंग है, मिडवाइफरी है, ये सारी बेसिक, अब तो वो एक एंड है, और दूसरा एंड है क्रिटिकल केयर नर्सिंग, जो एक नर्स ने और ज्यादा पढ़ के और ज्यादा अपने आप को प्रोफेशनली एडवांस करके एक स्टेज पे पहुंचे। तो इसी तरह डिफरेंट अदर सब स्पेशलिटीज हैं, नेफ्रोलॉजी की जो डायलिसिस में नर्सेज हैं, दे नीड अ स्पेशल ट्रेनिंग। यहाँ पे उनकी है, पाकिस्तान में भी होगी, लेकिन वी आर ट्राइंग टू फाइंड आउट कि अगर उनको और ज्यादा जरूरत है। यहाँ पे हमारे अपना मेरिट में एक नेफ्रोलॉजिस्ट का ग्रुप है, तो मैंने उन्हें बताया कि आपने नर्सिंग को इसमें पार्ट रखना है, तो जो नर्सिंग जो डायलिसिस यूनिट में पाकिस्तान किए हैं, विल फाइंड देम एंड मेक देम पार्ट ऑफ द नेफ्रोलॉजी मेरिट नेफ्रोलॉजी ग्रुप। इसी तरह जो है नूरमहल, वो बना रही हैं एक पल्मोनरी का ग्रुप, वो कलीम उनके साथ है, और वो जो है तो इस तरह वहां पे अगर कोई मतलब एस्मा की या बेसिक पल्मोनरी की जो है चीजें, उसमें अगर नर्सिंग को भी साथ साथ ट्रेन करें, तो दैट इज आवर एम, दैट इज आवर गोल। अब उसमें कितनी होती है, उससे के अलावा मैं कुछ गुड न्यूज, खुशखबरी आपसे शेयर करना चाहता हूँ। अब मतलब देखिए, पाकिस्तान में अब कोशिश है, कहाँ तक पहुंचती है बात, कहाँ नहीं, लेकिन लग रहा है कि काफी जो है ना लोग सीरियस हैं। अभी जो हेल्थ केयर टास्क फोर्स के चेयर हैं डॉक्टर बर्की, उनसे हमारी बात हुई आधा घंटा, और हमने शेयर किया ये सारा जो नर्सिंग का प्रोग्राम है और आगे हम क्या करना चाह रहे हैं। कोई किसी यूनिवर्सिटी से कोलैबोरेट करके ये जो मास्टर्स कोर्सेज हैं और पीएचडी कोर्सेज हैं और जो स्पेशलिटी नर्सिंग है, उसको किस तरह से हम फरोग दे सकते हैं, किस तरह से कर सकते हैं। तो ये काम तो सारा रफत और इनकी टीम ने करना है, हमारा सिर्फ है कि थोड़ा सा कह लें कि एनकरेजमेंट है, थोड़ी सी वही टीम वर्क की बात है। तो असल लीडर तो हमारे जो हैं वो रफत हैं और शबाना हैं और रोशन यहाँ पे नहीं है, लेकिन और जितनी भी आशिफा और बाकी जिन्होंने कंट्रीब्यूट किया, इस सारी effort में, और they came together. Really, they deserved all the credit. Of course, Dr. Noormahal Kabani brought them together. Really created a sisterhood and a group, brotherhood, also sisterhood. तो एक अच्छा ग्रुप, बड़ा अच्छा लगता है कि इतने अच्छे लोग, इतने competent, accomplished लोग जो हैं वो एक जगह पे आ गए. तो I think that is the main जो है ना एक कामयाबी. उसमें एक सबसे बड़ा ये है कि लोग एक जगह पे आ जाएं, एक टेबल पे आ जाएं, एक दूसरे से बात करें. उसमें से फिर जो है ना लाजमी अच्छी चीजें निकलती हैं. अगर जाहिर है कि सबकी इंटेंशन अच्छी है, सबकी नीयत अच्छी है, तो उसमें से ये हमारा तो मेरा और ऑफ कोर्स दानिश और इस सारी टीम का, रफत का एक मिशन है कि हम जो है ना इस पे चलते रहेंगे. और जो डॉक्टर बर्की हैं, उनका ये कहना था कि वो जो है इस चीज पे काफी डिसअपॉइंटेड थे कि जो नर्सिंग एक्ट है वो अभी तक नहीं हो सका. तो वो कहने लगे कि अब मतलब ये उनका है कि वो जल्द से जल्द उसको ला के उसको मंजूर करवाएं. तो एक तो ये स्टेप है. और दूसरा, उन्होंने इस चीज पे बड़ा एग्री किया कि जो अपना मेरिट्स जो नर्सिंग सेक्शन है, अगर ये स्पेशलिटी नर्स ट्रेनिंग की जो बात हो रही है, और प्लस उन्होंने कहा कि अगर एक्सचेंज ऑफ नर्सेस की बात होगी तो उसको वो सपोर्ट करेंगे जितना हो सकता है गवर्नमेंट के लेवल पे. और उसमें हमारा एक नेक्स्ट स्टेप ये होगा रफत के जो जितनी यहाँ पे शबाना और रोशन और जितनी अकॉम्प्लिश्ड नर्सेज हैं, वी हैव टू हैव अ मीटिंग सो दैट we need to know कि कितने पाकिस्तानी ओरिजिन नर्सेज जो इतने अच्छे ओहदों पे और यहाँ पे इतना अच्छा काम कर रही हैं, they are willing to go back and in person would like to involve in this kind of training. Because ये भी बात हो रही है कि वहाँ से कुछ नर्सेज आए यहाँ के कुछ इंस्टीट्यूशंस में वो ट्रेन हो, which is fine. We will find those institutions which will be willing, और उसकी क्या टर्म्स एंड कंडीशन होंगी वो देखेंगे. बट पर्सनली आई थिंक इट्स मोर कॉस्ट इफेक्टिव के बजाय एक नर्स आके यहाँ पे ट्रेन हो 6 महीने या 3 महीने या ज्यादा या कम, और एक बंदा ट्रेन होगा ना. यहाँ से अगर एक नर्स जाके वहाँ पे लोकल जो हालात है वहाँ के हिसाब से उनको ट्रेन और उनकी सिस्टम को भी देखना है ना कि पाकिस्तान में सिस्टम, क्योंकि जो यहाँ पे ट्रेन होके जाएगा वो वहाँ जाके मे बी और डिसअपॉइंट होके यार ये तो वो सिस्टम तो वो इतना जल्दी चेंज नहीं होता है. तो इसलिए जो यहाँ से फैकल्टी जाती है, अगर वो वहाँ पे 30 या 40 लोगों को ट्रेन कर सके 2 हफ्ते में या महीने में या जितना भी टाइम वो दे सकते, तो इस तरह के एक्सचेंज प्रोग्राम्स भी हमारे उसमें शामिल हैं जो बात हुई. तो आई थिंक अभी हमारी रफत मीटिंग का पार्ट है. एक यूनिवर्सिटी से बात हो रही है, फेडरल यूनिवर्सिटी से, कि वहाँ पे हम एक कोर्सेज शुरू करें और एक अच्छी लीडरशिप प्रोग्राम शुरू करें. तो ये जस्ट मैं आपसे शेयर करना चाहता था सारे ग्रुप से, और जो अटेंडीज और इस वक्त नर्सेज है पाकिस्तान में सुन रही हैं कि आई थिंक द गुड टाइम्स आर कमिंग. जो अच्छा वक्त है नर्सेज के लिए और नर्सेज प्रोफेशन के लिए, आई थिंक इट्स नियर. इंशाल्लाह जो ना मुस्तकबिल करीब में ये चीजें आप देखेंगे. लेकिन मेरी एक ये दरख्वास्त भी है कि नर्सेज जो जिस लेवल पे भी हैं, जहाँ पे भी हैं, ये कतरा कतरा जिसे कहते हैं दरिया बनता है. तो उसमें जो आप जिस लेवल पे भी जहाँ पे भी हैं, और ये जो आपने स्टेप लिया, ये इसका प्रूफ है कि आपके अंदर एक वो है तमन्ना है कि आप इसको अपने लेवल को इम्प्रूव करें, अपने जो कॉम्पिटेंस है, अपनी जो सीखा है नर्सिंग कॉलेज में उसको इम्प्रूव करें. तो ये जरूरी नहीं है कि आप बाहर आते हैं या जहां जाते हैं. आजकल तो इंटरनेट पे और फिर ये जो सारी चीजें हो रही हैं, वेबिनार, कोर्सेज, आपके अंदर ये ख्वाहिश होनी चाहिए कि आप एक बेहतर अगर आप अपने आप को इम्प्रूव करेंगे प्रोफेशनली और पर्सनली, आप यकीन करें कि आप मजबूर कर देंगे इर्द गिर्द के लोगों को कि वो आपकी इज्जत करें. एक ये भी हमारा बड़ा है कि नर्सेज की वो इज्जत होनी चाहिए जो वो डिजर्व करती हैं. और उसमें जाहिर है कि सोसाइटी और जो लोग हैं डॉक्टर्स एंड एडमिनिस्ट्रेटर उनको करना तो चाहिए, लेकिन मैं ये समझता हूँ कि अगर आप कहें कि हम क्या रोल प्ले कर सकते हैं, तो आप अपने लेवल को, अपने कॉम्पिटेंस को, अपनी पेशेंट केयर को इम्प्रूव करें जैसे भी हो सके, और जहां जहां भी आपको वो एक सहूलत या वो रास्ता मिलता है आप इम्प्रूव करें। खुद ब खुद जो है ना, वो फिर लोग उस चीज को देखते हैं। आई थिंक मोस्ट पीपल लाइक दैट एंड मोस्ट पीपल रिस्पेक्ट दैट। तो मेरा ये मैसेज है, और अगेन एट द एंड आई विल स्पेशली मोहसिन has been the pillar along with Noormahal, really bringing this group together. Kaleem has been from the beginning very supportive and caring. तो अल्लाह सबको रिवार्ड दे इस सारी एफर्ट का, और आगे भी इंशाल्लाह ये चलता रहेगा काम। तो बहुत शुक्रिया अगेन। जिस तरह रफत ने कहा, अगर मैंने किसी का नाम नहीं लिया, लेकिन it was a teamwork. It is a teamwork, and we will, do it together. Thank you, Sramik.
Thank you. Shabana, do you want to take over?
Yeah, sure. Well, thank you, Dr. Shahid and Rafat. That was really an inspirational talk. And I think most of the nurses that I'm reading in the comment has really inspired by what you have said, that nursing has moved far, far beyond to the point of just going and giving medications and giving injections and having a stethoscope around the neck. It has gone far beyond that. And I am glad to see that it's not just in the Western countries, but even in Pakistan. When I visited Pakistan after 7 years of my stay here in US, it has changed. Yes, it has changed. The standard has changed. And the way the people look at nursing profession is changed. It has become one of the competitive profession now. So it's not the time when I graduated and people would say, oh, aap nurse hain, aap doctor kyun nahi hain? And every time I used to say, मैं क्यों doctor बनूं, मैं क्यों nurse नहीं बन सकती? And say, आप इतना अच्छा काम करती हैं, ये तो काम करती हैं, तो नर्सों को काम अच्छा करना है, because I want to change the image. I want to change the way people look at nurses. Dr. Shahid, you're very right. There are doctors coming, giving us order of to do this and that, and there are pioneer, the integral part. But who is carrying out those orders? Who is the one spending time with those patients? Who is holding hands when they are dying? Who are the one who are wiping the tears and sitting down with them at the bedside and saying, I'm here for you. It's us, it's we. So this is the high time to change that standard a little up. And Dr. Shahid, you're very right in saying that this is up to us, our willingness. कोई भी आकर हमारा uplift नहीं करेगा जब तक ये will हमारे अंदर से नहीं आएगा. And Dr. Shahid and Rafat has given us a very, very good platform. Continue with that spirit, continue with that motivation, and things are not pretty far. We all are here, no matter we are in a different part of the world, but anytime you guys need any help, APPNA Merit has a very good platform. Just shoot an email, shoot anything, any kind of guidance you want, and we are more than happy to work with you. So as you know that these were our different course organizers. It was me, Dr. Noormahal, and Dr. Mohsin, a very, very integral part. You guys don't know Dr. Mohsin, when we were sleeping, he was the word up, jaag rahe hote the, hamari slides bana rahe hote the. So thank you so much, Dr. Mohsin, for that.
Oh, very welcome indeed. It was my pleasure.
And yeah, these are some of our core presenters on the screen, my nursing colleagues and my doctor colleagues. Thank you so much. It's really hard to take out time from the heavy schedules and work on this presentation and keeping in our mind the audience that we are talking to. That was really a challenging part of us, but you guys did a great, great job onto that. So thank you so much for that. Next
Dr.
slide.
Kaleem, do you want to say something? Dr. Kaleem, would you like to say something?
Well, no, thank you very much. Thanks for arranging this webinar. I'm very excited to see our nursing colleagues are, coming up to face the challenge and has the willingness. And definitely, I would appreciate if this project is going to go forward the same way as we are willing to do and play our role. So thank you very much to invite me to be part of this process, and I'll hope all the best.
Thank you. Go on, Shabana.
Okay, so again, these are some of our presenters, our co-partners with the with our webinar series, as Dr. Zaman was mentioned about. Next slide.
Mehak
Do we
and
have?
Shahruz are both here in case you
Oh,
want to
okay.
ask them.
Can you say? Can you please say something?
Mehak or Shahruz, would you like to say something? When I say
want to
Mehak, I mean
thank you
Mehreen.
for
I apologize, Mehreen. Do you want to say something? And Shahruz, of course, if you want to say something.
thank you for giving us the opportunity to present. It was a good opportunity to learn together, and with your help and Shabana and Dr. Noormahal, it was good to present and get a chance to present with this group. It was very good learning as well for us.
Mehreen?
So thank you so much, Dr. Mohsin, Dr. Noor, for giving me this opportunity. I was involved actively in teaching nurses in AKU during my COVID ICU days. So this was now a formal way, and I'm very hopeful that this is going to reach a lot of other people and a lot of nurses in Pakistan who do not get to learn so much. So this was a very good course conducted, and hopefully the next one is going to be even better.
Okay, Shabana, you can take over, and I will stop speaking.
Okay, so these are the countries, just the flags on it to represent our guests or our audience. As Dr. Mohsin mentioned, that I'm putting flag of Pakistan, it doesn't mean that he's in the leading. Well, he's in leading in a way. The participants were most from Pakistan, and then we had nurses joined from US as well. And of course, some of the nurses were from India and from UK. So it was not just, so we can see the diversity now. We can see just, it was not purely for nursing in Pakistan. It was nursing purely for the nursing profession itself. So that was really, really good to see so many different faces. And I think in one of the session, I saw one of the participants was from Philippines, and she joined us also. So, you know, heartfelt to see people coming from all the parts of the world. These are some of the feedback that some of our candidates have shared. So let's hear them. We can't hear Dr. Mohsin.
I wanted to say the sound issue comes back. These are the recordings from WhatsApp, but you can still see the sound is an issue. I apologize.
Yeah,
But they're short sessions.
In an ICU setting, we have to deal with many critical patients, and we perform many.
Oh, I'm sorry. You might want to put these in the on
I will
the
put them in the
forum.
group. Let me see if the next one is better.
I'm working as a charter.
Not really. Is this one better?
My name is Sidra Hafiz, and I have done.
Nope. And is
Yeah, I
this
think it's here.
This is a little better.
Accidental emergency surgical ICU of Gangaram Hospital from last 3 years. I'm a consistent participant of APPNA webinar of COVID-19 nursing. After all the learning provided through these online sessions, I have become much more competent in my work. All this basic knowledge of nursing skills have improved my ability of assessment. Now I'm much more confident in my work. Hopefully this opportunity will help me in future as well. Thank you. This is Abaza for working.
And the last message we got was earlier, 5 minutes before the webinar.
In the name of Allah, most beneficent, most merciful. Assalamu alaikum. I'm Bilkis Rana. I'm a critical care registered nurse. First of all, I am thankful to all APPNA merit team and especially Madam Rafat Jan for providing such a great forum of learning for Pakistani nurses. I'm proud to be a part of such a wonderful learning process. I attended all webinars with entire interest and enthusiasm. This learning process helps me a lot in my work and achieving my task in critical care unit. It is well said that breadth and depth of knowledge never ended, especially in nursing practices. We are learning daily new things. And as I was wishing for this course, that this will open the new doors of learning for me and it will strengthen my professional knowledge and competence, it does work. And still I am looking forward to expand my knowledge. Thank you so much, APPNA Merit team.
So the next thing we identified, this is just the two most common comments we got at the end of the looking through the feedbacks. And connectivity and sound were a big issue. and sadly, we can't do much about it because whenever the load on the servers was high, we would see that connectivity became an issue. The second most common comment was great job. When we asked, there was a specific question about how could we improve? The most common and consistent answer was well done, great job. You don't need to improve any more than what you have done, which is very flattering to be fair. But, and thank you for making that comment. And that's about it really. Now, something from Dr. Kabani, and then we will move on to something about your certificates. Dr. Kabani, you need to unmute yourself.
Sorry about that. Forgot that. All I want to say is that your journey has not ended. I would like to quote Rumi, your way begins at the other side. Become the sky, take an axe to the prison wall, which is the wall of ignorance, and get into your knowledge-seeking mode. Escape, walk out like someone suddenly born into color, and do it now. And this is Rumi, not me. The credit goes to him, but it's a great message to remember always. Think positive and move forward, and we wish you all the best.
Wonderful. Thank you for those wonderful words, Dr. Kabani. Just to update everybody, your certificates would be sent to you next week. Everybody who has attended a session, those sessions would be mentioned on your certificates to say that this is what you have attended. Your scores on MCQs don't really matter, so don't worry about it. It is an opportunity to learn, and the idea is to provoke thinking. It's not there to assess you and then grade you. That will come in the next course. Don't worry, that is coming, but not in this course. That comes later on.
I have a message from a participant wanting to say something if we have time.
Oh, please.
It's Ayaz. Mohsin, were you done with your? Sorry.
I'm done with my, certainly I can, let me unmute him or let me, oh, he can speak now.
Hello, Assalamu alaikum. Thank you to everyone of the Merit team. I am talking from Pakistan. It's a great job, and I have learned more of things from these sessions. I have attended all the sessions. Thank you, Dr. Mohsin, especially. He is very cooperative. There is a most time connectivity issue, but there is a very good and excellent things we have learned from them. I'm working as a nursing instructor in KTH. I have downloaded all these videos and I want to share with my student also. And the one thing I would like to say that, just like Dr. Shahid said, if they are coming from the foreign and train 40% in the Pakistan and as a master trainer, it will be very best for the Pakistan to do in all countries to improve their nurses, and that will train the further nurses in Pakistan. It will be a very better for Pakistan. Thank you, sir, and a lot of thanks to give me a chance for talking. And APPNA Merit, thank you a lot of thanks once again for this a great job and for this a great learning activities. Thank you, sir.
Thank you, Ayaz.
Wonderful. Anybody else from the attendees who wants to say anything? You're very welcome to do so.
Sorry, sir, just 1 minute. Sir, may I ask about something about the test and certification? Is it be in the next Saturday?
So what will happen is that there's no more webinars. You will now get an email. Those of you who have provided your emails, you will get a copy of the certificate in your email.
Okay, sir. Thank you, sir. Lot of thanks. Sir, and the more webinar will be started Yeah, maybe yes or no.
Then, Dr. Kabani, do you want to answer that?
I think we need to focus on the fundamental critical care nursing course. And, we can think about, after we have gotten the course going, to maybe continue an online discussion forum, which would be more practical than having two courses running at the same time.
Okay, so ma'am, one thing I should remember that there is a most need of cardiac CCU in Pakistan. Because of that, there is a higher ratio of cardiac in CCU and ICU, especially in medical ICU. There is a more need of the nurses to be more trained, because most of the patients are dead due to sepsis and cardiac arrest. So we have needed a team to make the CCU nurses, cardiac nurses. So for that, I have requested to all of, especially Ma'am Rafat, Dr. Mohsin, and Dr. Shahid Saab, to make a cardiac team and specialist and train the master trainer as a cardiac nursing. So it's a very honor for Pakistan. Thank you for that, ma'am, once again.
Sure. There is a very strong component of the cardiac module in the FCCN course, but we will keep your thoughts in mind for future. There's also a family practice cardiology group that can help with this. It's strengthening the cardiac nursing in Pakistan. We have to do it in stages to make sure that we have adequate time to cover it all, but certainly, totally agree with you.
I think Dr. Noormahal, they can send these kind of requests. So that will be good if they can send this kind of request.
Absolutely.
And I was requesting, if it's almost 2 hours, if we can end this session.
Yes.
I agree with you that rather than webinar, we now concentrate on the course, and we are going to discuss what other webinars are going to come that we are going to post for other specialties as well.
I can told that you made specially for the cardiac special webinar, like just like you have taken 6 classes on the different
I asked if you can,
so
if you can put this, yes, if you could please put this in an email and send it to apnamerit.com, it will get to us.
Wonderful.
Okay, ma'am. Thank
Okay,
you.
everyone. Thank you for joining. And we will say goodbye at this end. And thank you all the presenters for coming back. And thank you for Prof. Rafat Jan, Dr. Noormahal, and of course, Dr. Shahid, for being supportive and allowing us to do what we have been able to do so far.
Thank you.
Thank you, Mohsin.
Thank you. Assalamu alaikum.
Walaikum salam.
Okay, assalamu alaikum ji. Thank you.
Thank you.
Thank you. Allah Hafiz.